Get those headphones on, and we are live on the 10th edition of the LA Shoulder Podcast. This is the segment at ASES we're doing this year, and I have with me a wonderful and special friend, a special guest, Dr. Andrew Green from Rhode Island. He's a shoulder specialist. He's a shoulder and elbow specialist.
Yep.
You treat elbow still?
Still treat elbow.
Still treating elbow.
Yep.
And he's a professor of orthopedic surgery. He's, I'm not going to give you the full rundown because it's going to take 20 minutes to go through your CV. He's one of the leaders in shoulder surgery, and he's a very well-respected member of the ASES. So welcome, Andrew Green.
Thank you, Michael. It's a pleasure to be here with you.
Yeah, I'm happy to have you here. So one thing that we wanted to discuss, and you and I have been in several discussions over the years about the natural history of arthritis. And you've done some extensive research on the natural history of arthritis. And in fact, you have a big paper coming out pretty soon that you're going to submit for publication. Is that right?
They've actually been submitted. We don't know what's going to happen to them, but they'll be out somewhere.
Yeah, good, as they should be.
It's a process, right?
As they should be. So tell us what's unique about this study in particular that we're going to go over.
So what I've been interested in now that I've been in practice for 30 plus years is what happens to patients who have osteoarthritis over time. Generally, patients come to our office because they have pain, and we treat them, and some of them we treat with physical therapy or medications or injections. Some end up having surgery soon after that first visit, but a lot of them go away. And what I've started seeing in my practice is people coming back. And it was the opportunity to be able to say, okay, I saw them this many years ago and this many years ago, and to look at what's happened to them over time, because we know what osteoarthritis is. There are characteristic findings on x-rays, the way patients present, whether they have pain and limited motion, but we don't know how that progresses over time. And typically when we see people in our office, they're at their worst. That's why they're in our office.
And that's what you mean by natural history.
Yeah. So right? What happens over time? Yeah. How does it progress? And we don't really understand why patients have osteoarthritis. There are some studies that have looked at the actual shape of the bone, the scapula and the humerus, to say, okay, patients who have this type of glenoid, retroverted, are more likely to develop arthritis. But then there are different types there are patients who have, as you're aware, A-type Walch glenoids, which are concentric.
Different wear patterns.
Different wear patterns, yep. So a concentric where the ball and socket match each other, and then B-type where the ball is shifted posteriorly, so it's subluxated, and then they get wear on the posterior or back part of their glenoid.
Right, eccentric wear, right? Exactly. So there's more pressure on a smaller point of the glenoid.
Exactly, and we don't know why some patients have that and others have A-type or B-type, and my theory is that probably it's not the same condition, but we call it osteoarthritis. So right. I thought because I have access to all these patients and all these records, including their x-rays, we could look back and see what happens to patients over time. So the first cohort, we have probably at this point over 500 patients who have x-rays with a minimum of 2-year interval up to more than 15 years. So that means someone who came in 15 years ago with shoulder pain, we had an x-ray that showed arthritis, and here they are 15 years later, back again.
That's very rare to see how those patients do and keep track of those patients.
Yeah.
Which sounds odd, right? Because we keep track of surgical patients. Those are easy to keep track of, but non-surgical patients, that's very interesting.
We actually it was all serendipitous because we were actually not keeping track of them. They just were in the same location and they came back. And it may have a lot to do with where I practice, which is Rhode Island. It's very densely populated area, but it's small. Close
community.
Yes. Yeah. So the first group we looked at was...
And just sorry to cut you off. How did you include... So obviously there's a lot of people, arthritis is a wide spectrum. How did you include patients to say you're going to be included in this study as far as how extensive your arthritis is? How did you grade that? Was it mild, or if there was any kind of changes on the x-ray?
Everybody was included. Anybody who had a previous x-ray with sign of arthritis early on, we just included them. Yeah. And it's a retrospective, so the patients didn't have to consent because we had all their records. So the first group we looked at was the patients who had minimum of 5-year interval between their x-rays, so 5 to 16 years, I think it was. And I thought, well, if we looked that far, in that group, we would definitely see changes. we would expect that over that long period of time, they would have gotten. So, that's
some kind of change that you could see on the X-ray,
that
right?
we could see. Yeah.
Right.
So that was about, I think, 135 or 40 patients. At the time of their initial presentation, they were 62 years old or so, with a range of 41 to 80. So it's a broad spectrum of individuals. We ended up having a mean follow-up of over 8.5 years. So on the average, and that ranged from 5 to 16.5 years. And what we saw was over that, and we used a variety of parameters to assess their X-rays. We used classification systems. We used Samilson Prieto, which is one classification for osteoarthritis.
How big the osteophyte is, right, off of the humerus.
Yep.
Yeah.
And that was originally not for osteoarthritis, but it was for capsulorophy arthropathy. But it's the same pattern that we see.
Right.
We used the Kellgren Lawrence classification, which is a classification developed for arthritis in multiple joints, but there's characteristics that you use to assess how severe they are.
Yeah, it was developed for the knee, I believe, right? Kellgren, but it was adapted to the shoulder.
Yeah, it's been adapted to multiple joints. And then the Walch classification and then we looked at plain radiographic parameters that have been found to be related to the development or the presence of osteoarthritis. So we looked at humeral head spur size, the critical shoulder angle, the acromial index, humeral head flattening, humeral medialization, so shifting of the humeral head medially, and then humeral head medialization angle, which we came up with as a way to kind of measure medialization and flattening, and then humeral head subluxation. And these are all plain radiographs, no CAT scans. And we had. Was there any limitation on that? Did you have any limitation on your X-rays? Say they were not the right axillary and you had to exclude them, or did you have any issues with exclusion, or did you have a strict exclusion criteria? So the exclusion criteria was you had to have good true AP X-rays. Okay. But the majority did have axillary X-rays as well. At least some axillary. Yeah. We had quite a few actually. We didn't have to exclude many for that. Okay. And then we also assessed, at least at their most recent follow-up, because that's when I was identifying people, what their range of motion was, patient-reported outcome scores, because we routinely get that on our patients coming into the office. And then a subgroup of those patients, we actually had outcome scores at the beginning, so from the first time, and range of motion. So what we did see was, as expected, there was significant progression of all the radiographic parameters and the classification grades over time. And we expected that. Interestingly, when we looked at the Walch type, about 30% of the patients who we thought had an A-type glenoid at their initial presentation now had a B-type. That's interesting. So you saw some progression in a crossover in the Walch type. Yes. Yep. And then we also saw progression in the B-type. So they became more severe, B2s becoming B3s. And the shift from the A to B is interesting because and maybe they weren't actually A's at the beginning. Maybe they were about sub-Bs. Right, they're about to become a B. Yeah. So we haven't looked at other parameters such as acromial tilt and whether there's some issues that we might be able to identify to explain that. And then there were also significant differences or changes in the spur size, the flattening of the humeral head, medialization of the humeral head, and humeral subluxation. So clearly, as we expected, there was change in the severity of their osteoarthritis over time. But then we looked at factors, radiographic or factors, or radiological factors, or classification factors, the association between those and their outcomes. I see. So what we were able to find was, and that was at a subgroup analysis where we had their patient-reported outcome scores. So in an larger initial humeral head spur size was associated with lower future ASES score, greater VAS pain, and lower EQ5D or Euroqual 5-dimension quality of life score. Mm-hmm. So that was interesting because we don't really we focus on the glenoid in osteoarthritis, but now we're seeing that there are actually aspects of the humeral head which are important. Right. The larger initial and final spur sizes were also associated with less range of motion at latest follow-up. And then on the latest radiographs, a severe Kellgren Lawrence was associated with lower ASES scores, lower SST scores, VS pain, and less range of motion, which you would kind of expect if the more severe type.
Right.
Progression of humeral medialization was associated with less active forward elevation and less active external rotation. So medialization is often associated with flattening, so it's not as round, so you start to lose more motion.
These are some of the ways that you measure these X-rays.
Yep, that's how the technique we use for all the measurements.
Perfect circle technique for the center of rotation, and then making measurements off of that, including offset of the acromion. Several. So these are all validated measurements.
So we were told on a recent publication we looked at the perfect circle, but we were told we needed to call it the best fit circle.
Best fit circle. That's what we're calling it now, right? Yeah.
So the conclusion from this was at mid and long-term follow-up, there's significant radiographic progression of disease, and that is associated with worse clinical manifestations. But there are early radiographic findings, such as larger humeral head spur size, that are associated with worse future clinical manifestations. So you can say now, if you see a patient who has a larger spur, that over time, with non-operative management, they will have worse outcomes. I mean, it doesn't tell you that you need to operate on them, but it is somewhat predictive. But it's the second part of this study was, or the second phase kind of was, we asked, does the radiographic progression of glenoid osteoarthritis relate to the decision to undergo shoulder arthroplasty?
Yeah, that's a good question.
And so we took the same group, and of those 135, I think it was, where I got it here somewhere. About half of those ended up having, I guess the data's not, there's a table probably. Yeah, let's see. And we're referencing the tables. No, the tables are all statistical. Anyway, so about half the patients had elected to undergo surgery at that most recent follow-up time, but half did not.
I see. And what did you find what it was dependent on? Was there any kind of predictor?
Yeah.
For those who had to go on to surgery?
Yeah. So both groups had significant progression. The shoulder arthroplasty group had significantly greater proportion of patients with the most severe Kellgren Lawrence stage at that final follow-up. The more severe Kellgren Lawrence was associated with having a shoulder arthroplasty, basically. The conservative group had significantly less pain, better ASES scores. They're not great scores, but they're above the MCID. So there's a 12-point difference there.
It's pretty interesting that the non-surgical group had less pain. They were less severe, but
the non-surgical, so less pain. And then their simple shoulder test scores were better than the surgical group.
Wow.
Worst VAS scores at final follow-up were odds ratios almost 1.5 associated with increased odds of undergoing shoulder arthroplasty, while better ASES scores and simple shoulder were associated with decreased odds. So there's patient-reported outcome factors that weigh heavily in a patient's decision whether to have surgery with advanced arthritis. But I was surprised that there were that percentage of patients who went that many years, because if you see a patient today with severe arthritis, you'd look at him and say, well, probably in a few years, this person's
you'll be back in a year or two.
Yeah. I mean, one of the limitations of this study is that we haven't yet fully evaluated the patients who have 2 to 5 year follow-up. And we may find that in that cohort, there's a high percentage that elected to have surgery, so that's why they didn't go out that long.
Right.
And the total group is probably 500 patients. So there's another 350 or so that we're just finishing doing the radiographic parameters to look at. But I think this is really important work because, one, we're getting a better understanding of how does it progress. I think we will probably be able to sort out, are there certain types of arthritis, like a B glenoid versus an A glenoid, that are maybe more likely to undergo surgery sooner rather than later, because we don't know it. We don't understand any of this. We understand the condition. We think we have a good handle on the treatment, but we don't know the natural history.
You said the A2s crossed over. Did you find any particular Walsh classification?
A1s.
Or, I'm sorry,
A1s,
A1.
yeah.
Did you find any particular Walsh classification that had a higher either risk or rate of progression? Meaning that if you're a B2, you're much more likely to turn into a B3, for example, or that you're at a higher risk of progression. Did you look at that type of analysis?
Well, I mean, the issue is, so an A1 is only going to progress to an A2,
right?
But some of the A1s became a B.
Some did. That's the interesting, is the ones that cross over.
Yeah.
But did you find that it was less often the crossover wasn't as likely, or was there not enough data to do like a sub-analysis for that?
You mean whether they had surgery?
Yeah. Say for example, with the natural history, if you have a B2 come in, what's their rate of progression? What's their likelihood of progression to either a further stage or to cross over to another stage?
So we know, B2s, there were
I guess the only one would really be an A to a B, or it would be a B progression, right?
So there were no B3s at initial presentations, and there were almost 16% B3s at that later follow-up. So you do see progression. You see B2s become B3s,
right? And
B1s become, so the B1. So there was a B0 at the beginning. The B1s, there were 11 that went down to 6. So all the Bs had progression.
They progress.
Yeah. Everything.
So there's something.
Everything progresses.
Everything progresses. Yeah. It doesn't get better.
No, it doesn't get.
Yeah, it's going to be stable until it reaches the point that I can tell the difference on the X-ray, pretty much, right? Until it makes that progressive crossover where we can agree that there's been a change, right? You can say, because your study looked at, yes, there is progression, positive progression, but it may not be enough to go from a B2 to a B3, right? You still see, you're looking at just radiographic changes that progress.
We're looking at the classification change, and yes, there's probably B2s that are a worse B2. But we didn't.
Right.
We weren't.
They're right on the cusp of becoming a B3. Right.
Or they're a little bit of a B2, and now they're a lot of a B2.
Right.
But not
a more pronounced B2, for example.
Yeah. But where we see that come through is in the medialization. So because a B glenoid is going to allow the humeral head to medialize as it articulates.
Right, by being more posterior.
Yeah.
So So this is a lot of data to unpack. How do you find it useful to take this much data, or I should say, like, what is your process for taking this much data and then getting it into some usable way that, obviously besides constructing the study, but what are you going to do with all this data? Are you going to try to parse it out with one kind of overarching theory about the natural history of arthritis, or is this going to be more of a sub-project with multiple parts?
So we're doing more work on this other cohort, but within our institution, one of the things we're interested in now is gene expression in glenohumeral osteoarthritis, and looking at, is there a difference between an A-type patient and a B-type patient? Do they have, I don't think they're the same disease.
Because now you've identified these patients, and then you can look at the genetic factors associated with the people that we already know as a case control, where we know who develops the arthritis and where you were in the past. So we should sample those particular people.
Well, we weren't,
and then compare them potentially. Is that what you're saying?
No, that's there is something you could do there, but what we're going to look at is actually operative specimens and use. They can do single cell gene expression on the articular cartilage. So we'll harvest articular cartilage that's remaining in these patients.
It's like pathologic cartilage, I imagine, because you're there for surgery, right? But you're taking, or do you try to take the healthiest sample you can find, or the?
Well, we'll take out the head and whatever cartilage.
But you send what you have.
Well, the lab can process. I mean, they I don't know the technology.
Sure, but they get it.
They can do it with one cell.
Oh, wow.
And tell you the gene expression. Look at RNA. But I think from a more clinically based, what I'd like to do is we have a multi-centered group for natural history of osteoarthritis. One is to get a bigger cohort of patients from this group to be able to do the same type of thing, have more data, and set up a prospective study, which would take years.
Sure.
But one of the things we can do with our cohort is, now that we've identified patients, we could now enroll them in a prospective study going forward, and we've got this. The other thing that we need to do is really look at patients who have more mild arthritis, because what we're looking at here is patients with more severe arthritis, and it may be a very biased population. And you may find that someone with mild arthritis, it may take them 30 years to develop, or there may be some that progress faster.
Do you look at this data and do you say this is something we might be able to intervene on? Maybe that we can find a point where drug development or pharmaceutical development with, different types of biologics combined with medications that we don't understand yet could change that course of progression of arthritis? Or do you think this is going to be useful information from a more of a surgical perspective? Like, how do you look at this data?
I think potentially both. So from a treatment standpoint, I think what it may do is inform patients and surgeons that they don't need to say you need a shoulder replacement, because the way I look at it in my practice, nobody actually needs a shoulder replacement. They get to a point where they want a shoulder replacement.
I tell them the same thing.
It's, this is not cancer or heart disease.
Right.
You'll be fine, but it's how much pain and quality of life issues can you deal with.
Right.
But there are patients who,
and this shows you're not too bad. Maybe you don't need surgery because you're not doing that great. But compared to the people who've gone through surgery, they're dealing with their own surgical problems too.
Yeah, and then the flip
not
side,
risk-free.
The flip side might be, especially if you have bad surgery and you have a complication.
Well, hopefully, hopefully. I mean, but these we all know you're doing reverse replacements. There's fractures, there's dislocations, even done by great surgeons and great patients that listen to you. Sometimes they just happen. We know.
And then the flip side might be that we might say, you know what, we identified that patients who have this early presentation are bad actors, and their shoulder, you could expect that in 5 years, this is how bad it's going to be. And maybe if they're on the cusp, this would be the time to intervene when they could have a more straightforward surgical reconstruction.
Sure. Yeah. A lot of people want to know if they can wait or not. And a lot of times we tell them, I tell them, we'll come back next year and we'll get an x-ray. And if it hurts a lot worse before that, you'll come and find me.
Right. Yep.
But otherwise, we're kind of just monitoring how things are going. And I tell them, I do say natural history. I say these are kind of how this degenerative process goes. And with Dr. Andy Green's work, we'll have a little bit more light on that topic. I think this has been really helpful. I think the work that you're doing is obviously you're a very thoughtful guy, thoughtful surgeon, and really a thought leader in the field. And we're lucky to have you, because we need people trying to solve these problems.
Always nice to hear that.
Yeah. Well, thanks for coming on my show and spending some time with me. I know you have other engagements today. So
as always, Mike, great to see you.
Thank you. Is there anything else you wanted to bring up before we wrap up? No. All right. Well, good talking to you. I appreciate your time.